So good morning, everyone. It's a pleasure to be here to talk to you a little bit today about high-risk uterine cancer. And, fortunately, this doesn't make up a large percentage of uterine cancer that we treat, but it certainly is a very important part. Outline of the talk, I'll tell you a little bit about the epidemiology of uterine cancer, how these cancers are classified, the patient characteristics of these different types of cancers, how we treat them, and where I think we may need to go in the future. So as Dr. Valea mentioned, we see now an ever-increasing amount of uterine cancer. And this is all uterine cancers, which are endometrial cancer, cancer of the lining of the uterus, cancers of the body of the uterus, the muscle of the uterus, but almost 50,000 cases a year. And that's caused by several factors. One, it's the increasing age of the population. It's estimated that the incidence of cancer is going to continue to rise as the population gets older. People are living longer, so we're seeing more of these types of cancers. And there also is, as Dr. Valea alluded to, an epidemic of obesity in this country. And a lot of the uterine cancers that we deal with are related to obesity. Again, as mentioned previously, when we talk about uterine cancer, I'm going to focus mostly on endometrial cancer, which is cancer of the lining of the uterus, as pointed out by Dr. Valea. But there are other cancers. I shut myself off. What I do here? Okay. But there are other cancers that we deal with, also cancers of the muscle of the uterus, as well as what we call the stroma, which is the intervening connective tissue inside the uterus. So the development of endometrial tumors, endometrial cancers, are thought to happen because of two separate pathways. And this is what we talked a little bit about before. The pathway towards type 1, the classic type of endometrial cancer that we deal with, and the type 2 cancers, the more aggressive subtypes that we deal with. So the normal lining of the uterus has what we call glandular epithelium. There's a certain characteristics that the glands have. And then sometimes these glands undergo a growth. There's a heaping up of the lining of the uterus, and that's known as hyperplasia. Simple hyperplasia is not really considered a precancerous condition, but it can continue to grow and become complex, and it's really when the cells become atypical, complex atypical hyperplasia, that there's a significant risk for moving on to develop cancer. And often when we detect the lesions at these earlier stages, sometimes in younger women who want to preserve their fertility, we can treat them with hormones to try to save the uterus and don't have to go straight to a hysterectomy. We can treat them with Megace, which is an anti-estrogen, or other forms of progesterone, and then repeat an endometrial sampling or a DNC. And we can cause a conversion back to a normal endometrium. These women can go ahead and get pregnant, which actually, pregnancy is a very high progestational state, so that's actually very beneficial. So if these women can get pregnant, that will be very beneficial as well. But once it progresses to complex atypical hyperplasia, especially in the postmenopausal women or women who are not interested in childbearing, the treatment really is more likely to result in hysterectomy. And studies now have shown this distinction between atypical hyperplasia and endometrial cancer is a very difficult one for pathologists to make. And studies have shown that if a woman has a diagnosis of atypical hyperplasia on a biopsy or a DNC, often, in at least 40% of cases, when you remove the uterus at the time of hysterectomy, you'll find cancer in the uterus. The other pathway, there we go, thank you. The other pathway is the pathway that leads to type 2 endometrial cancer. Now this arises in the background of an atrophic endometrium. So these are not associated with estrogen. They're not associated with a heaping up or a growth in the lining of the uterus. But this is a thinned out menopausal endometrium. And these are the type of cancers that are more aggressive. And really they arise by mutation. There has to be some sort of a mutation that occurs that leads to sometimes a precancerous condition, what we call endometrial intraepithelial carcinoma, and ultimately leads to the more aggressive types like the type 2 serous endometrial cancer that we heard a little bit about. Again, the mechanisms of these two types of cancers, the type 1 cancers, again, associated with estrogen, either use of exogenous estrogen, taking estrogen replacement therapy or taking unopposed estrogen, and also estrogen that's produced in the body secondary to obesity. If you're wondering, we talk a lot about obesity and endometrial cancer for good reason. One, because many endometrial cancers could be prevented if we could encourage weight loss, take a more proactive stance to try to help patients lose weight. But again, the mechanism for that in postmenopausal women is that you really don't produce a great deal of estrogen from the ovaries when you're menopausal, but the adrenal glands and the ovaries still secrete testosterone, or forms of testosterone, namely androstenedione. There's an enzyme contained in adipose tissue, in fat tissue, called aromatase. And it's that aromatase reaction that converts testosterone into estrogen. So that's the link between obesity and endometrial cancer. Obviously, the more adipose tissue you have, the greater your weight, more of that androstenedione, more of the testosterone is going to be converted in the fat tissue into estrogen. So that's why there's a link between obesity and endometrial cancer. But the type 1 cancers tend to occur in younger patients. They tend to have a better prognosis. They're mostly what we call endometrioid adenocarcinoma. The type 2, again, as we said, arising in the background of an atrophic, thinned-out endometrium in postmenopausal women, tend to occur in older women, tend to be high-grade lesions. These include the papillary serous and clear cell cancers, and again, tend to have a worse prognosis, and I'll explain why that is the case in a few minutes. Dr. Valea mentioned the molecular profile of these cancers. This is good for a research standpoint. We know that the type 1 cancers tend not to have mutations in the p53 tumor suppressor gene. The type 2 cancers do. And again, profiling tumors is becoming a very important part of what we do in oncology nowadays, and it's important to learn what the common mutations associated with different cancers are, especially now in the recurrent disease setting, when if patients perhaps undergo surgery and then either chemotherapy or radiation therapy for their initial treatment. If they recur and you biopsy that recurrence, you can profile that tumor to see if there are any specific mutations occurring in the recurrence that you could target. And that's what a lot of the new current cancer chemotherapy trials are. They're looking for targetable mutations, that we have new drugs that you can use to treat or to target those mutations and perhaps result in a better outcome for those patients. So endometrioid carcinoma is the most common endometrial cancer that we deal with. Serous cancers, perhaps accounting for about 10%. And then there's rare forms of cancers, including mucinous, clear cell, squamous, undifferentiated carcinoma, and sarcomas, those tumors that arise more in the muscle of the uterus, accounting for about 5% of all uterine cancers. So uterine papillary serous cancer, this really resembles ovarian cancer. This, if you look at it under the microscope, looks almost identical to ovarian cancer. It's more common in African American women. These tumors tend to lack estrogen and progesterone receptors. They're not associated with a state of increased estrogen. Most of them, unfortunately, present with advanced stage disease. They often recur even when they're confined to the uterus. But we do know that the outcome is better when these patients are comprehensively staged. There's a real shift occurring in surgery for uterine cancer, specifically endometrial cancer. We've gone from the days where we didn't stage anybody to the days where we comprehensively staged everyone, took out a large number of lymph nodes, pelvic lymph nodes, aortic lymph nodes. There's morbidity associated with that, specifically lower extremity lymphedema, swelling of the legs. And there's a national study now which is taking patients who are undergoing surgery and doing baseline measurements of their lower extremity to calculate the volume of their lower extremities, and then following the patients very closely with serial examinations every 3 months after surgery to really get a handle on what the true incidence of lymphedema is following these pelvic and aortic lymph node dissections, because we really don't know that. Doctors actually don't look for this and don't measure it, and until a patient complains about swelling of the lower extremity, then they'll refer them to someone who deals in lymphedema. So what we're hoping to gain from that study is a better understanding of what the exact incidence of lymphedema is. We also have a symptom checklist that patients will undertake. This is the protocol, in case you're interested, is called GOG 244, We're also doing a symptom checklist because there's some evidence in the literature that symptoms of lymphedema occur before actual change in physical measurements. In retrospect, when you look at some studies, women will complain that there's a heaviness in their mons pubis, the part above the vulva. There's a heaviness in their thighs. So we're looking for what some of those symptoms are, because if you can detect lymphedema early before some of the actual physical measurements change, there can be a better outcome in preventing the long-term consequences of lymphedema. The other great thing that the study is doing is trying to quantify risk, and that risk can be based on preoperative factors, age, race. African American women, in a study of vulvar cancer in patients who underwent inguinal node dissection, this was a study by the GOG, 100% of them developed lymphedema, compared to 60 to 70% of Caucasian women. So very important to look at these risk factors. So we're putting together what's called a Venn diagram: preoperative factors, intraoperative factors, length of surgery, type of surgery, number of nodes removed. Postoperative factors: did you get chemotherapy? Did you get radiation therapy? Did you develop an infection? And when you take all these factors, you can create a model and then determine who is the patient at highest risk for developing lymphedema. And then you can be proactive about following them closely and trying to initiate treatment as soon as possible. So I think that's an exciting part of that, this story. But in the meantime, though, there is some evidence that in patients with papillary serous cancer, if you comprehensively stage them, if you do that node dissection, if you do that complete node dissection, to make sure that they don't have metastatic disease, perhaps you can avoid giving the early stage patients chemotherapy and or radiation therapy and avoid the morbidity of those treatments. More and more the pendulum now is shifting in the United States for patients with the lower grade lesions to not do these ultra-radical node dissections, but to actually base node dissections on uterine factors, as Dr. Valea mentioned, depth of invasion of the cancer, size of the tumor, grade of the tumor, or to do something called a sentinel node mapping, like we do for breast cancer, where we actually inject a dye into the cervix and then follow that dye as it comes out of the uterus and goes to the lymph node chains in the pelvis, and just take the first one or two nodes. Those are called the sentinel nodes. They're like the sentry, the gatekeepers. If they're negative, we assume everything beyond them is negative, so you don't have to remove all those other nodes. If they're positive, you have your answer. You don't, unless a node is enlarged and you're removing it just to remove the bulk of tumor, once you know a node is positive, you're going to treat that patient. So you don't need to know if another one or two nodes are microscopically positive. With advanced papillary serous cancer, and these sometimes present like ovarian cancer. They could have fluid in the abdomen, or they could have a lot of disease in the upper abdomen involving what's called the omentum, the apron of fat that hangs from the stomach. We do what's called debulking. There is some evidence that that helps in this disease, just like it does in ovarian cancer. If you can remove the majority of the disease, ideally all of the disease, then the outcomes could be better. In terms of therapy, and I guess it's good to focus a little bit more on that for this talk, you know, for papillary serous cancers, we have this desire to give chemotherapy, you know, because we know that these patients have a high incidence of recurrent. The truth of the matter is that no data supports, if there's no metastatic disease, if you comprehensively stage them, and I do think for serous cancers, we feel you do have to comprehensively stage them. Although now what we're doing is we're doing sentinel nodes and comprehensive staging to see if we can eliminate the need in the high-grade cancers for doing the full dissection. But there's no data to support giving chemotherapy. When we say adjuvant therapy, that's different than when you give chemotherapy to someone who has disease. Let's say someone has disease, you're giving chemotherapy for treatment to shrink a mass or to eliminate a disease that has spread. Adjuvant therapy means there's no evidence of disease. You've taken out the uterus, you've done the staging, so there's no evidence of disease left, but this is almost given as a preventative measure to prevent the cancer from coming back. The reality is with papillary serous cancers, there's no data to support giving adjuvant chemotherapy for stage 1 and 2 disease, But giving chemotherapy, and I think some of it is like just a visceral reaction. We just want to help our patients. So look, we know this disease has a 50% chance of coming back. We kind of got to do everything we can now. It sort of makes sense, right? I guess as a patient, I would want to do something for me. You know, I've got a high chance of recurring. But the reality is, are you really benefiting the patients? You know, there are toxicities, significant toxicities associated with these drugs. So we really feel you should reserve treatment for advanced stage disease. So what is treatment for advanced papillary serous disease? Well, the treatment for all advanced endometrial cancers, a lot of it has been outlined by studies done by the Gynecologic Oncology Group, which I think is considered by most the premier group to look at clinical trials in patients with gynecologic cancer. So one of the earliest studies was GOG 122, and this was a study that looked at chemotherapy with doxorubicin, or what's commonly known as adriamycin, and cisplatin, compared to whole abdominal radiation, which is pretty toxic therapy. And that study showed that there was an improvement in survival in patients who had chemotherapy. So this is really the study that told us in advanced uterine cancer, really chemotherapy plays the most important role, not radiation therapy. Subsequent studies looked at different drug combinations. GOG 177 looked at adriamycin and platinum, but combined Taxol, which is, of course, a very important drug in the treatment of ovarian cancer. And this study showed that the response rate and what we call progression-free survival was improved with the 3-drug combination over the 2-drug combination, but there was a lot of toxicity gained for that, and not a real significant effect on survival. The response rate was 48% for patients with serous cancers versus 45% for patients with non-serous cancers. So about an equivalent response rate for patients with advanced serous cancer compared to advanced endometrioid cancer. GOG 209 looked at the 3-drug combination and compared it to really what's known as the community standard. It's a lot easier to give carboplatin and Taxol. It's often done in an outpatient setting, doesn't require hospitalization, and has significantly fewer side effects than adding adriamycin, which again is a very tough drug to give. So the combination was not shown to be inferior. The 2-drug combination was not shown to be inferior to the 3-drug combination. So I think really this is now what most people treat advanced endometrial cancer with, carboplatin and Taxol, and avoid the use of adriamycin, perhaps saving it as second-line therapy if needed. We talked a little bit about the racial disparity. Dr. Valea touched on that in African American women versus Caucasians. And this is really important because when you see a disparity in outcomes, it's very fertile ground to do investigations that kind of show you why that's the case. You learn from that. You say, well, why is that different? What's going on here? What's unique about the tumors in one group of patients versus another? And we talked about that tumor suppressor gene earlier, P53. It's overexpressed in African American women 3 times more frequently than in Caucasian women. And it is associated with a poor prognosis, even in patients with stage 1 disease. P10 mutation, one of the most common mutations that we see in endometrial cancer, is associated with a favorable prognosis, actually. And it's more frequent, 4 times more frequent in Caucasians than in African American women. So it's very important to look at these differences in racial groups and see what's occurring, why this is the case. What's interesting is, from a quality of life perspective, a lot of women, premenopausal and postmenopausal women, have a lot of side effects from the therapy we give. Specifically, if we remove their ovaries and they're premenopausal, they might have hot flushes or vaginal dryness, puts them at risk for osteoporosis. So there was a lot of controversy as to whether or not you could give estrogen replacement therapy to women who had endometrial cancer. So the Gynecologic Oncology Group conducted a randomized trial in women with endometrial cancer, and they were randomized to getting estrogen versus a placebo, a sugar pill. And that study, which was the largest study done to date, over 1,000 patients, wasn't completed, didn't reach its accrual goal because the Women's Health Initiative results came out and a lot of people were getting very concerned about giving estrogen. But it still was over 1,000 randomized patients, and it did not show a higher rate of recurrence in women with endometrial cancer who you gave estrogen replacement therapy to. So we often, if our patients are symptomatic, we'll give them either Vagifem, vaginal estrogen, or if they need systemic estrogen, we'll give them estrogen replacement therapy. We think the data shows that that's probably okay to do. What's interesting is Larry Maxwell, who does a lot of this work on racial disparities, found, he went back and he looked at GOG 137 and found that that didn't hold true for African American women who took estrogen replacement. They did have a higher recurrence rate than the group that got placebo. So it's not like one size fits all. We always have to make sure we know which groups we're looking at. We have to learn from these factors why that is the case. So estrogen replacement therapy, when you went back and looked at GOG 137 and stratified it by African American versus Caucasian, or Caucasian and non-African American, there was a higher rate of recurrence in the group that got estrogen. So this is just a compilation of trials from GOG, again done by Larry Maxwell, who's done so much good work in this area. 169 African American women, 982 Caucasian women with stage 3 or 4 or recurrent endometrial cancer treated on 4 GOG chemotherapy trials, on any one of those 4 trials. Black women were more likely to have papillary serous, stage 4 disease, and higher tumor grade than white women. And survival was 25% worse among African American women than Caucasians. So one of the things that people look at is this a lack of access to care amongst different populations? So what this study was showing was patients who obviously have access to care. They're treated by specialists, by gynecologic oncologists. They're put on cooperative group trials. Dr. Valea mentioned about the difficulty of getting patients onto trials. But these are all treated on trials of the GOG, and yet there's a significant difference in outcome. So this has nothing to do with access to care. This has to do with biology. And boy, we have to take advantage of these biological differences to help our patients. If we can learn why these patients are doing differently, then we can act, hopefully act. And as therapies get better in the future, we can provide these patients with better treatments. Clear cell cancers resemble the serous cancers, again, more common in African American women who, as Dr. Valea mentioned, have a lower incidence of uterine cancer, but yet when they get it, they have a worse type. They also lack estrogen and progesterone receptors. They're not associated with obesity, and many present with advanced disease and can spread even without invasion into the uterus. So some of the current ongoing trials in GOG that are ongoing right now in terms of where we are in terms of therapies, GOG 258, endometrial cancer, patients with stage 3 or stage 4 disease, or stage 1 and 2 papillary serous or clear cell cancer are allowed. So remember, stage 1 and 2, this would be considered adjuvant therapy versus the advanced stage patients who are getting treatment. But for the stage 1 and 2, this is adjuvant therapy. So this trial will hopefully, in a randomized manner, answer that question. If you have papillary serous cancer or clear cell cancer and you're comprehensively staged and don't have any disease left, will you benefit from treatment? And what are the treatments? Well, it's the standard treatment, which is platinum and Taxol, and specifically carboplatin, given for 6 cycles. And it's randomized against volume-directed radiation, which is either radiation to the pelvis or to pelvic and aortic nodes, followed by cisplatin and paclitaxel over 3 hours. I'm sorry, excuse me, I apologize. The cisplatin is given with the radiation to enhance the radiation. We know that in many diseases, in cervical cancer and perhaps in uterine cancer, when you give concurrent cisplatin, you sort of think of it like lining all the cells up, and then the radiation is like the bowling ball that kind of comes and knocks it all down. So that's kind of like a visual way of thinking about why we give chemotherapy with radiation. It's felt to enhance the effect of the radiation. But in this study, this group of patients will get combined chemotherapy and radiation therapy, followed by 4 cycles of carboplatin and Taxol. And I think we look forward to the results of this study, because this will hopefully tell us in the stage 1 and 2 papillary, serous, and clear cell cancers in whom we don't have evidence of metastatic disease, if those patients will benefit from getting additional treatment. Sarcomas, rare brand of uterine cancers, again accounting for maybe 5% of them. Carcinosarcoma, that's that mixed tumor that Dr. Vallejo alluded to. Is it a sarcoma? Is it a carcinoma? Tumors of the muscle of the uterus, leiomyosarcoma. Then we have tumors of the intervening connective tissue between the glands called the endometrial stroma. Those are endometrial stromal sarcomas. And then we have the undifferentiated sarcomas. So again, it's a small number of the uterine cancers that we treat. Worldwide incidence, 0.5 to 3.3 per 100,000 women. And if you look at SEER data, that just shows you the incidence per 100,000 women. So leiomyosarcoma sort of in the middle of the pack. So carcinosarcoma is an aggressive tumor. It contains both the glandular elements, the elements of the lining of the uterus, as well as sarcoma elements, which could be muscle, rhabdomyosarcoma, could be cartilage, chondrosarcoma. It is associated with obesity, nulliparity, and increased age. One thing that was found in the large NSABP trials, the cooperative group that studies breast cancer, there's always been this concern that tamoxifen increases the risk of endometrial cancer. It appears that it does, but those are usually low-grade cancers, grade 1 cancers. There is evidence when you pool all of the NSABP trials and look at patients who had tamoxifen versus placebo, like many of those trials were randomized to do, there was a higher incidence of carcinosarcoma. But you have to remember, there's relative risk. You could say that something has a 7-fold increased risk. That's the relative risk, which is true. Women taking tamoxifen have a 7-fold higher risk of carcinosarcoma compared to women who didn't. But then there's absolute risk. So it might be 7 times higher in one group than the other, but if the absolute risk is, 2 or 3 per, 10,000 or whatever, the absolute risk is really low. So I don't want people to think that just because you take tamoxifen, you've got a huge risk of getting a carcinosarcoma. Have a higher risk than the women who didn't take tamoxifen, but overall the absolute risk is very low, on the order of, less than 2 per 1,000 per year, or even less than that. So for carcinosarcoma, again, we look at the GOG. These are rare tumors, so the GOG has looked at this. GOG 150 looked at whole abdominal radiation versus cisplatin and ifosfamide, and it showed a 21% lower recurrence rate in favor of the group getting chemotherapy. So again, we're seeing this theme that in most uterine cancers, chemotherapy plays a more significant role than radiation therapy. GOG 161 showed a 14% improvement in recurrence rate for patients receiving the combination of the drug ifosfamide and Taxol versus ifosfamide alone. And the current ongoing trial is looking again at old reliable, the community standard, what we use in so many of our diseases that we treat, carboplatin and Taxol versus ifosfamide and Taxol. So this will hopefully shed light on what's the best current regimen for treatment of this disease. Leiomyosarcoma is a tumor of the muscle. This is a smooth muscle tumor. 0.1 to 0.3% of patients operate on for leiomyomas may be found to have a leiomyosarcoma. This is usually discovered by serendipity. It doesn't often present with postmenopausal bleeding the way endometrial cancers do. Sometimes you just operate for fibroids, you take out the uterus, and you just incidentally find leiomyosarcoma. One of the fallacies out there is that a rapidly enlarging fibroid is associated with leiomyosarcoma. That's been looked at. That's probably not true. Fibroids can increase rapidly because they outgrow their blood supply. They can undergo what's called degeneration. So really, I would say, obviously, if a woman is postmenopausal and her uterus is growing rapidly, it's safer to take the uterus out. You have to be concerned that there might be something going on. But we see consults all the time where we see women who the doctor feels the fibroid is growing very rapidly, it needs to have surgery for sarcoma. And just the literature just does not support the fact that rapidly growing fibroids equals sarcoma. The problem with leiomyosarcoma is that when you operate on these patients and you find leiomyosarcoma, most of them recur, or at least half of them recur, even if it looks like it's confined to the uterus. Now, the treatment is for leiomyosarcoma is to take the uterus out. In a premenopausal woman, you can take the ovaries out. It's sort of controversial. About half of these tumors do contain estrogen receptors, but it's not clear that there's a benefit in taking the ovaries out. And there's no clear benefit to doing staging, because leiomyosarcoma, if it's spread, it spreads to the pelvis, to the upper abdomen, to the lungs. It tends not to spread via the lymphatic route. So we tend not to do comprehensive lymph node dissections in women who have uterine leiomyosarcoma. And most of the patients we see will already have had a hysterectomy and then get referred to us afterwards for treatment. So should you go back and do a lymph node dissection or take out the ovaries? Those are the questions that often arise. But if you know a patient has a leiomyosarcoma ahead of time, which we sometimes do, they may have had a D&C that picked it up, we don't routinely remove lymph nodes because there's no clear benefit in doing that. And I mentioned that there. In terms of postoperative treatment, there's no data which would advocate for the use of pelvic radiation therapy after you operate on a patient with a leiomyosarcoma. It should be reserved for patients who have localized disease remaining after surgery, or as treatment for the patients who recur in the pelvis. But if you just give radiation therapy after surgery, there's no benefit to doing that. As I said, half of uterine leiomyosarcomas recur regardless of stage, with the most common sites being the pelvis, abdomen, lungs. They can recur in a variety of sites. It is what we call a hematologic spread pattern. It tends to spread via the bloodstream, so it can go to all distant parts of the body. And we talked a little bit about the role of surgery, radiation, and chemotherapy. Chemotherapy is becoming more important in this disease. If you look at the response rates to drugs, it's on the order of about 10 to 20%. One of the most active regimens for treatment of uterine leiomyosarcoma is a combination of drugs, gemcitabine and Taxotere. Currently, based on work that was done as part of the SARC trial, this was done as a phase 2 trial, and again, the adjuvant setting, patients who had their uterus removed were given gemcitabine and Taxotere, and this appears to be now probably one of the most active regimens for this disease, followed by 4 cycles of adriamycin. And 78% were progression-free with a median follow-up of almost 2 years, and the progression-free survival was 39 months, which is much better than what's been reported in other regimens. So the GOG does have a trial for stage 1 uterine leiomyosarcoma, which involves gemcitabine and Taxotere for 4 cycles, followed by adriamycin for 4, versus observation. This trial is not doing well. It's hard to put patients on a randomized trial of treatment, right, guys? Of treatment versus no treatment. If you tell a patient that, we think you have a 50% recurrence rate, and we're going to put you on a trial, hard, right? Most patients say, well, 50% recurrence, I want it. But the fact of the matter is, we don't know if giving this toxic treatment, and this is toxic treatment, is going to improve outcome. And the only way to prove that is to do a randomized trial and see one group. And I guess what you can tell the patients who don't get the treatment is we don't know if it benefits you in this setting. It is very toxic. And the good news about not getting the treatment is you have those drugs, which are very powerful drugs and very effective drugs. The most effective regimen right now for leiomyosarcoma is gemcitabine and Taxotere. You have that in your back pocket to use in case you need it in the future. But I understand the difficulty. I can only imagine from a patient's perspective, you're telling me there's 50% chance of recurrence and you're going to give me nothing? That's a hard thing to wrap your head around. I may have put this slide out of order, but for measurable disease, this is, and Dr. Hensley, who's at our institution at Sloan Kettering, has done a lot of work in sarcoma. This is the regimen of patients, looking at patients with measurable disease, gemcitabine and docetaxel. This is GOG 87L. And patients, if they had received pelvic radiation, of course, the second regimen on the bottom, they got lower doses of the drugs. So this is why this is the most effective regimen. This is the study that showed this. There was a 36% response rate for patients getting this cycle. And what we call a clinical benefit, 62% of patients benefited from this combination. So response rates in GOG phase 2 trials in advanced uterine sarcoma, as you can see, we mentioned that they were on the order of about 10 to 20%. And as you can see, this regimen right now, gemcitabine and docetaxel or Taxotere, is the most active regimen now known for treatment of leiomyosarcoma. Endometrial stromal sarcoma, I'm almost done. These resemble the endometrial stroma, the connective tissue in between the endometrial glands. These are hormonally sensitive tumor. They're highly estrogen and progesterone receptor positive. They have an excellent, excellent prognosis, usually with surgery alone, and usually don't require any additional treatment. There is a variant of them called undifferentiated endometrial sarcoma. They don't express estrogen and progesterone receptors, and they are very aggressive, have a very high recurrence rate, and they do show response rates of up to 30% for the combination of doxorubicin and ifosfamide. So that was, I think, a good, complementary to what Dr. Valea talked about. I focused, I think, a little bit more on the actual treatment of the disease. But these high-risk uterine cancers, up to 20% of them, they tend to behave aggressively. They are more common in African-American women. Physicians tend to have less experience treating them because, of their rarity, and obviously we strongly feel that these should all be seen and treated by gynecologic oncologists or medical oncologists that specialize in the treatment of gynecologic cancer. And the therapy does continue to improve. That response rate seen with gemcitabine and Taxotere, that doubled the response rate that we were seeing with adriamycin for leiomyosarcoma. So things are getting better, as new drugs come out. I didn't have time to talk today about some of the targeted therapies. This is the whole push in oncology, profiling tumors and determining what mutations patients' individual cancers have, because they come in many different flavors and they have many different mutations, and not one size fits all. The days of just blanket treatment for everyone with the same drugs, those are ending. Maybe in the upfront setting it's okay, but for recurrent disease, you need to find out if there's a specific mutation that can be targeted and that there's an appropriate protocol for. But this is why it's so important to participate in clinical trials, because unless we do that, we're all partners in this together, the patients, the doctors, the clinicians, the nurses, we're all partners in this, and until we can do these trials and learn from them, we won't know what the most effective treatments are. And the sad fact of the matter is that it's getting harder and harder to do clinical trials, specifically randomized trials. I think the days of the phase 3 randomized trials are, frankly, probably over. Everything is going to be phase 2, smaller randomized trials, and this is unfortunately a consequence of funding at the NCI. So I think the GOG this year has had all of its, this is kind of sad news to say, but all of its phase 3 trials were not approved by CTEP, which is the regulatory body at the NCI. But that doesn't mean that we won't be able to make progress. We'll have to do more focused trials, phase 2 randomized trials. As we learn more and more about the molecular etiology of these tumors, I think as we develop more targeted therapies, the news is only going to get better and better. So just hang in there. Thank you for your attention.